First of all, thank you for having me here. It's a really honor to try and share our knowledge and work with you. Great admiration from a lot of people in the US for your country. You know, spending just when you just realize, Russia is a superpower. You are a small country that's really fighting for your freedom and living your lives the way that you believe should be lived. And this is really for soldiers and family members that are really suffering. That it's just amazing courage. No matter what your political situation in the US, you have many people support who are defending the Western freedom and the way of living that people should be living. Also being an old, like this is my fifth training, and then thinking you are so eager to learn, you want to move forward and not backward. It's really always a pleasure to be here and share with you what we know. So thank you for what you stand, and thank you for hosting us here. So I'm going to talk about post-traumatic stress disorder. We study that what I'm treating for 20 years now, both in military veterans. Unfortunately, war is very big. It's also women in our society that suffer a lot. And sometimes then we forget that. There is a lot of sometimes violence against women, and there are also something that we need to remember that it's going on, and so we treat trauma, to be aware of that. So that's something that I struggle always with in my work. I'm going to try to talk about the diagnosis so we can understand and conceptualize the patient that you work with, because that will help you to create the best treatment for them. Because sometimes it's very confusing, and the clinical picture. It's not that you come in and you have a patient in the ER with a chest pain and you take a cardio measure and you have an objective measure. And it doesn't matter, say, if its pain is 10 or 8, they might have the same. Or you have a patient with a broken bone. You can measure, 7 millimeter fraction, with movement, without movement, you can measure, but how you measure emotional pain, it's really a difficult concept. And we use language. And language means different things to different people. So we try to get this perspective between the language and the biology, so we can find a path. If it's psychotherapist, what you're going to focus on. Or if you are a psychiatrist and a psychotherapist, what medication to address and what to approach with medication and what's need more psychotherapy. So we want to thank we are working together. We have at Yale University organization that called Doctors United for Ukraine and raising money, and we brought some doctors like a surgeon and other doctors to do training. They are spending, we pay for the tickets and stay with us for several weeks just to learn new techniques of treatment, and that's something that we really are working hard to achieve. So we know that post-traumatic stress disorder in soldiers, that's so common, about 20% of them will develop post-traumatic stress disorder. So one out of 5 soldiers, coming from the war, most likely going to have PTSD. In the general population, the prevalence is around 8% of people in their lifetime will experience that. Want to talk about the first step of diagnosis PTSD, and this is also a human-made construct. Okay, it's you need to meet a criteria A. The first one is that you have to expose to trauma. Okay, and it has to be, very strong one. It has to be death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. But I always struggle because it has to be direct exposure. It's happened to you, or you witness it's happened to someone else. But the doctors that created that decided that now you can also be indirected, like if you are a medic, and it not necessarily happen to you, but you are hearing it over and over again, you might develop PTSD. So you don't have to be directly exposed to that, you can just hear about it. It cannot be like because you're watching too much TV and news. But if it's indirectly, the event, as I mentioned, it has to be violent, okay, or accidental. But if I'm just taking a perspective, let's say you have a mother, a parent, that their child has a chronic illness, and they are destined to die. Okay, and it's an expected event, it's not violent, but after they lose their child, they have, intrusive memories. So they hear every child crying, make them have a strong emotional reaction. They have, depression, they really feel very depressed. They avoid going to the children's room. They cannot bear it anymore, and, so they meet all the symptoms, but the criteria A not. So how are you going to treat it? You're going to treat it as something else, or you're going to treat it? So remember, we are treating human beings. We're not treating diagnosis per se in mental health. We are treating diagnosis, but we have, above all, we're treating humans and the clinical picture in front of you. So, because again, that is human-made subjective system that we created. So a lot of responsibility is on you as a clinician to make the right decision of what treatment to go forward with. So I'm going to talk about the signature diagnosis is the intrusion, the re-experiencing of the PTSD. And I want to separate those, although they are coming together, you can think about two systems maybe of re-experiencing, that even maybe I'll talk about it later in treatment, are driven by two biological systems that are need different treatment. So the re-experiencing is unwanted and upsetting memory that you experience, nightmares, flashbacks, and then you have emotional or physiological reactivity after you are being exposed to trauma reminder. So, but think about emotional reactivity or physiological reactivity. You need something to remind you, and then you're getting like overwhelmed by that. And we'll talk about it. It's like overgeneralization of fear. You just see things that are not anymore dangerous or related, and then you are experiencing emotional. So you want to maybe treat it in one way. But how you nightmares? You have no triggers. You sleep. It's coming out of the blue. And some people talk about that they walking and there is internal cue that triggers that. And those are the traumatic memories that are fragmented in the brain. You're working with patients and they talk about the trauma, but it's not a coherent story. It's just, oh, the soldier next to me was bleeding, and I was, not paying attention, I don't remember, and they jumping. So the memory really like looking for a story, reorganization of a narrative that you need to reconstruct with the patient. So because it's internally, the body is looking for some cohesion, autobiographical story of this trauma. And one of the reasons that those patients cannot construct is because they avoid it all the time. They avoid the story, it's so painful. So they don't want to visit it. So it's interfering with the memory ability to create a whole story, autobiographical story, how bad it is, no matter if your brain still need to have a story of what happened. So people avoid any reminders, they avoid any thoughts about it, and that's really interfering. Because, things that happens to us in life, and we go out and something bad happened to us. But then we can talk to ourselves. We can talk about friends and family, say, yesterday I was in the street and some guy beat me, took my wallet. I thought I'm gonna die, it was scary, but how stupid I am, why I'm going 2 a.m. in the morning, by myself. So you're creating a story, but if you're just gonna stay, ER, panic, coming home after you get, treated and just leave it, it's gonna stay fragmented. So we naturally in life tell stories, rethink stories, and the trauma memory is always fragmented. So this is kind of something that we need to remember when we talk about the treatment tomorrow, more in detail. So the other, so we say re-experiencing, avoidance, and the third one is negative alternation in mood and cognition. So, and I want to look at that as two systems too. I know I'm breaking things to you, but there is the notion that you have negative belief about yourself, about the world and others. This is very cognitive system. You have guilt, shame, you done things badly, and or your friend did something bad and you didn't intervene, and you can feel guilt about that, or you can feel anger and resentfulness to other people, but those are very cognition that we have ideas about right and wrong and moral, what is moral and not moral. So that will mean one way of treatment, because the other one, negative affect, decreased interest in activity, feeling isolation, no positive affect, this is like anhedonia. This is like MDD, really a deficit in the reward system. So here you need to probably maybe medication will be the first line of addressing that, major depressive cluster in PTSD. In the diagnosis is a one whole system, but when you are a clinician and you're intervening, if someone has those thoughts, cognition that is driving the depression, that's a different approach than someone that just cannot come out of bed, just feel so miserable, you have zero energy, and you don't know, maybe it's just kind of a totally, dampening of the reward system that you need to address in a different manner. Although it's in the same diagnostic group, we are looking at two different systems here. That you need to think, you are a psychiatrist, psychotherapist, how to address it. And if you're a therapist and have no medication, this dampening of the reward system, usually, you can do like what psychotherapists do, like you prescribe behavioral activation, doing something positive, go out on a walk 5 minutes a day. Or you work together with a psychiatrist that can prescribe, but you can also prescribe, you say, okay, you're home, you have to do that, Not that we know that the patient will do it, they say, please do something good, hug your partner, for 5 minutes a day, no matter how bad was the day, you're just prescribing positive activities to them. Whereas the cognition is a totally processing, talking to the patient differently. So the last one is called alteration in arousal and reactivity. And again, I'm sorry that the DSM is a mess, but we saw also 3 different systems here, biologically. So you had hyper-vigilance and heightened startle reaction. So how is heightened startle reaction, like you say you hear something that reminds you of the trauma and you jump and your heart started to race, how it's different from, let's say, criteria. Remember, at the beginning, there was physiological reactivity to reminder. It's probably driven by the same biological system that I called overgeneralization of fear. That I will talk about it in a minute in more details about the neurobiology. And then we have irritability, aggression, risky and destructive behavior. We see that patient has a diminished inhibition. They are becoming much more irritated, angry, and they act in a very aggressive way. But this is a totally different biological system that also operates. It's in a control inhibition, prefrontal cortex, or, and we have difficulty of sleeping and concentration. That's, transdiagnostic, and that's also might be a totally different system. So, just to be in line with the diagnosis, it has to be more than 1 month, because during the first month is acute stress reaction, so you don't diagnose PTSD in the first month. And after a year, if there is no symptoms not getting better, is called a chronic PTSD. And it has, of course, to have a social, occupational, and other area really deficit. You need to start to get this diagnosis, because you might have a symptom, but they're not severe enough to interfere. and it cannot be due to substance or other medical condition. Those are the pure DSM diagnosis. And in the ICD-9, ICD-11, actually now, the ICD only has re-experience, avoidance, and hyper-reactivity. They don't have this depression cluster that in a DSM-5. So it always strikes me because at the hospital we use ICD-9 to ICD-11, 10 actually. We are coding based on the ICD, but we're using in our head the DSM-5. So it's just always amazing when we do the coding. But you can think of how many symptoms are listed in the DSM, and when you take all the possibility to have a diagnosis based on the DSM, you can have 600,000 people line up, and each one will have a different symptoms profile. So this is kind of show how the problem is with the DSM-5 diagnosis, because how we can create treatment to 600,000 different patients. So I think, like, as a guidelines, we can also think about this. Okay, this is a busy slide. So what I want to just, when you're working with the patient, you have to think about exactly like what kind of approach and the diagnosis within post-traumatic stress disorder you want to focus on. So what PTSD is also associated with, you see there is a lot of strain, interpersonal and family relationship, have a very hard time to get along with family. A lot of difficulties of staying at work, working, and having, positive experience. We see like a change in personality in some of those patients. And something very strong is also the survival guilt. That you survived and other people did not survive that. And as you look earlier in the picture, when we have all the symptoms, it's just a lot of overlap with depression and anxiety symptoms. So it's very hard to see patients with just PTSD, correct? You always see a lot of depression, MDD with it, substance use disorder, and of course high level of anxiety. So that's something that we need to rethink and work with. Some of the symptoms you can think on PTSD are very adaptive to soldiers. When you are in a war, and I served 10 years in the military, when you are in a war zone, you want to be hyper-vigilance, you don't want to be surprised, so you're always looking around, you are checking if there is no danger, and that's something adaptive. But it's hard to switch that off when you come back home. It's become like a way that your body reacts to the environment. So this is a system that is really adapted in a war zone, but there is inability to turn the system off. And that's why PTSD is called a failure to recover condition. Because when you take a lot of people after a traumatic event and don't treat them, as I mentioned, 20% develop PTSD, but 80% just get better by themselves. And that's 20% are something in the system doesn't let them recover from what happened to them. Where if you take those people that were exposed, let's say we have the soldiers from the same event, that everybody experienced the same trauma, you know, maybe a day or two after, most of them will have a PTSD symptoms. Everybody will be very jumpy, very nervous. They will, you know, have this re-experiencing, but they will talk about it, where others will not be able to talk about it. So, like, I remember when we were in a war with Lebanon, and we went, and my vehicle was hit by an explosion. And I remember I was standing and I was shaking, and like for a minute I thought I'm going to die. But I'm thinking I'm going to die. And then we realized that, you know, we were able to move the vehicle. It was not totally damaged, but I was frozen. And then we moved and were able to get out of the situation, but for like 2 weeks I was so nervous, but slowly, the system started to adapt, and I understand, okay, now I'm in this place, it's safe, okay? I'm talking about what we did wrong, what we need to do, what happened, where some other people got so, you know, caught up in that and did not want to talk about it. I would assume that later on they're at high risk to develop post-traumatic stress disorder. But most of the people recover, but 20% is a lot still. You have to remember, you know. I'll talk about the risk factor, you know, so the severity, how severe, how bad it was, really affect the likelihood to develop PTSD, you know. Usually if it's like gruesome, you know, very graphic scenario, that will be more likely to develop PTSD. If you have physical injury, and you know, I know that here I really went with the psychiatrist on, you know, on around in the surgical unit. You know, you see those people with physical injury that really dealing with amputation, and those are more likely to develop post-traumatic stress disorder than other people. If it's a man-made versus like natural disaster, you know, people like in Japan, earthquake, or you know, it's hurricanes, they less likely than if it's something that, and you can see how the mind, you know, when it doesn't make sense to you, it's make it more worse. Like work sometimes doesn't make sense, so. And it made it much harder to think about it. And as people that experience trauma at young age are really at higher rate to develop PTSD. So if you were a child and you went to the war, but as an adult, but as a child you experienced a lot of trauma, you know, abuse, something bad happened to you, you're more likely to be more vulnerable to develop post-traumatic stress disorder. What we learned over the years, that even social support, having a network of people to help you when you come back home, and you're not just by yourself, you have like a spouse, community of other soldiers, you connect with other people. It's extremely important component, social support. It's not like a kind of medical term, but it's extremely, like so many research have done in recent years to show that social support, and also people talk about resiliency. So something that came up is purpose in life. Having a purpose in life. It can be spiritual, religious, or something else. For non-religious people, really help people to be more resilient in the face of trauma. So also the concept of purpose in life. So I'll talk about the neurobiology. So in the brain, there is like 3 major areas that there are more, but let's talk about the prefrontal cortex, you know, and the hippocampus, where episodical memory are stored usually. and the amygdala, where it's like kind of the measuring of the level of stress, associated with the memory. And for the amygdala, it's this part of the brain making a rapid processing and initiating the response to fear. So kind of also encoding some of the traumatic memory, the emotional memories, some of components that are being stored in the amygdala. The prefrontal cortex area is over, executive functioning, planning, rational decision making, and directing social behavior. And we know in stress studies and PTSD that it's kind of inhibits the amygdala activation to stress. So if you see a reminder and get, very alarmed, then if you start to calm yourself down, say, okay, I'm going to put, this is a prefrontal cortex, but it's kind of putting the brakes on the amygdala and trying to calm you down in that processes. And hippocampus. So hippocampus is kind of really short-term memory, new learning processes, contextual learning. So you have cognitive map in the hippocampus, like in space and navigation is really happening. But for us, the episodic memory storage within the hippocampus, that's also combined with the cognitive map, because this episodic memory is also embedded with the context. And it also helps to shut off stress response. So if the connectivity between hippocampus and amygdala is extremely important in shutting off stressful responses. So stress creates really bad things in the brain, and that's a lot of imaging study happens. So if you're going through a tremendous amount of stress, continuous chronic stress, okay, we start to see some changing in the human brain. And you can think about the soldiers that are in the front line, that are in stress all the time they're thinking, or it can be, we see it in people that living in a very stressful environment, okay? And we talk about this inability to look, to shut off, this hyper-vigilance. So on the left, you can see like neurons before being exposed to stress. But after a lot of stress, you see like really loss in dendrite spine and branches. This is kind of in exposure to chronic stress. So you're like your system in the brain changed. You started to lose some connection in the brain due to this chronic stress. You see it also in young children that went through a lot of abuse. Like you see that really affect the brain. What was interesting in, we'll talk about it in emerging treatment. If you look to the right, if you give ketamine to animals like rats or mice, 24 hours that were like you did a model of prolonged stress, you see a neurogenesis. Those neurons in the prefrontal cortex and the hippocampus after ketamine experience neurogenesis. So we thought, and we'll talk about the last day, maybe it's a good time to make new intervention because we're rebuilding, some synaptic connection in the brain with ketamine that also have a very strong antidepressant effect But the area that we see over and over again in the brain that being affected, and the huge enigma, it's a big study that collected a lot of data from many centers and combined, thousands of images, and we see that the hippocampus, there is a deficit in the smaller hippocampus with people with PTSD. And again, it's unclear 100% yet if it's a consequences or a predisposition. I don't think we still have an answer to that. So, but we know that smaller hippocampus is significantly smaller in PTSD. So let's talk about enhanced and over reconsolidation of traumatic memory. Okay, we talk about some damage to the brain, but I want to talk about over consolidation. And the idea is that emotional experience has really strong impact that leave a scar on our brain. It's so strong that James, already before neurobiology was invented, talk about that, and we know we tend to remember, emotionally strong events better than neutral one in our life. We'll remember happy, sad things. That's not included. Trauma memory, we'll talk about it. Maybe it has a special things in the brain, but we have to, and I realize that this is scar, and when we talk about it, I just spoke to my mind, it's not in the slide, is that when we have, we lose a limb, you're always aware of it, it's always not there. So in trauma, you have to accept that you have something. It's maybe something that we want to remember when we work on a patient. We cannot change what happened. We cannot go back and grow an arm, you can have a prosthesis. We cannot undo the trauma. We're just going to help the patient live with it and deal with it and cope with it. So we have to remember not to have the expectation to change what happened. We can't. So I talked about this in a way that emotional memories are almost stay forever, and fear memories are really hard to extinct. Why it's so hard to extinct them is because they have a survival value. We're not talking about trauma here, but things that are bad for us, we need to remember them. You don't need a child to put his hand twice in the fire. The brain learned one time, one exposure, that it's not a good idea to put a hand twice in the fire. So you don't have to relearn that, correct? You don't have to teach that. It's one time, the brain will learn it forever. It has a survival. If I go with my friend to a safari and a tiger eat my friend, next time that I see a tiger, I'm not going to check if it's friendly tiger, I'm just going to run. You don't have to do it twice. The brain learns. So when something bad happens to you, it's very hard to forget it. And we have to realize it because it had so strongly survival value. So one of the ideas is that, why we remember those memories so vividly, it's because the epinephrine and norepinephrine enhance consolidation of long-term memory. Okay, and those are the same neurotransmitters that are being activated in a fight or flight situation. Mm-hmm. It helps you to focus on the danger, okay? and then remember that. So this is kind of biologically geared for us to remember. But, okay, but this is kind of danger. But what about traumatic memory? So I want to talk about a new hypothesis that we are working now in our understanding of PTSD. So when you're bringing memory into consciousness, it's become unstable. And do you know this concept of memory reconsolidation? Or I need to talk about it more? Most of people know that when we remember something and then you store it back in the memory, before you store it back, you can change it. That's why we have a lot of false memories sometimes also. So I think that this is kind of a window of opportunity also for psychotherapy in the future. But what we wanted to say is maybe traumatic memory, the things that happened to you in this horrible situation, are not really able to consolidate. They stay in a different part of the brain, not in the hippocampus even. So is trauma memory, if you have 0 to 100 bad memories, is trauma memories 100? Just really bad sad memory, or it's a totally different kind of memory, not even related to bad memories. You see where I'm going here? It's just kind of different type of brain area that involved with it. And what we have done is we collected memories of people with post-traumatic stress disorder, and then we played them back, those traumatic memories, in the MRI while they were listening to their own PTSD memories. But we also measure their brain activation when they talk about very sad memories, okay? And then we measure the brain when it's listening to neutral memory, because when you're doing MRI study, you need to measure activation from something. So what is the brain is moving all the time and active. So you're measuring how much the brain is activated in sad memory compared to neutral, and how much the trauma is related to neutral. So that's why you need a neutral memory to work with. And that you can do, those are really complicated slides, but what you can do is you can play the music, oh my God. You play the memory that said the trauma, the neutral, and you can see how the brain, let's say, the amygdala activate while you're talking. And you look even in the level of each voxel, you take the hippocampus or the amygdala, you divide it to a small unit of activation, and you see how that correlates together. I don't want to be complicated, but the idea that we talked earlier about sad memory keeping forever, and they are so ingrained, what we found is that sad memories, when you listen to them in the MRI, the brain across all people behave kind of in a similar way. There is some synchronization between the way that people talk about the sad memories and what they listen to. And then you can see that this pattern is similar across all those people. But there was no synchronization across individuals when they listened to the trauma script. Okay? Not at all. We found that this synchronization in the area of the brain, the PCC. And the PCC is the area that, you know, when you do a resting state, time, you know, you have wandering, you know, it's one of the major nodes of what the, in the default mode network. It's just when you daydream, you're thinking about other stuff, and it's also the area of the brain that a formation of new autobiographical memory is kind of being initiated. So we realize that actually trauma memory is totally different kind of memories that are not yet organized in the hippocampus as a whole story. They are still fragmented, looking for us as a therapist to make sense of it, to create a story that will be stored in the hippocampus as a long-term memory. So we just show that actually it's totally different kind of memory in human, the trauma memory. So it's not like, okay, you put it in the hand in the fire, you know something is dangerous, you learn it forever. Here you're not even learning, you're still processing it like you are in a kind of a daydream, wandering state of mind without really coherent story around it. So we talk about, I want to talk about fear conditioning and failure to extinct. So we talked about this diagnosis. Remember, we talked about the re-experiencing symptoms, the intrusion. That's exactly what the PCC, like the memories, needs your help. Okay, we talk about that notion. That, you know, we talked about the depression. We talk about the cognitive component that needs you to talk about, you know, we'll talk about dealing with moral injury later when we talk about treatment and how to deal with moral injuries. But the other system is that you avoid, correct? You're not going to places, you're not doing a lot of things. You have this hyper-vigilance, jumpy, emotional. So this is really derived from a really biological system that we call overgeneralization of fear. Okay? You know that overgeneralization of fear, you probably heard about, I'm sorry to bring the Russian into this place, I didn't mean to, but Pavlov. You know, he originally, what he showed that, you know, you give an animal, there is, let's say, a noise, a bell rings, you bring food, okay, several times you repeat it, and then, you know, you just press the bell, and then the dog will start to salivate. Like he knows that the bell, you know, predicts something that happens. And there was other studies, and we did it in humans. This is like you can also create fear, not just food or reward. You can also create like you have a mouse that hear a beep, and then after the beep there will be electric shock, and then you teach them that that's gonna beep predict a shock. Then you take the shock away, the beep still, the animal will freeze, they will have heart rates, and they will release stress hormones. So this kind of overgeneralization of fear into the specific biological system. So when we are experiencing trauma, all the sensory aspects of the events are working together with context and everything, and there is a visual, auditory, tactile, what is called olfactory activation of the element, and they are encoded together. It's called olfactory. And then what happened is people, let's say I was in the front line and then a garbage bag explosion and my friend died. Now I'm starting to be afraid of all garbage bags. And then this is not going away. It's become stuck in my memory. That's kind of overgeneralization of fear. I was in a car accident and it was a red car, and suddenly you started to become of all the red cars. And you started to avoid things. So all those symptoms are driven by the same biological system of overgeneralization of fear. And that's why we are in treatment starting to create conditions that we re-expose the patients to those, what they perceive as dangerous environments, but are not dangerous. We create an inhibition. We're trying to shut off the system of overgeneralization of fear. So this is kind of other thing that we're talking about when we're talking about treatment. So again, to summarize, it's just that we want to understand that how messy is the PTSD diagnosis. So again, we have the intrusion, the yellow on the top. That's what you want to do when you're working in trauma-focused psychotherapy. You're helping the patient take these fragmented memories that are not yet become an autobiographical story of the self. You want to create a story of the self to this patient that they can hold on to. We're not in the business of erasing memory, okay? We just make it tolerable. So you can live with it, it's painful. It's okay to cry. When we remember bad things, there's nothing wrong with it. But if you cannot deal with it because it's so painful and you avoid it, it's going to continue to haunt you. In nightmares, suddenly out of you walking out the street and you're going to have a re-experience and you're going to go under a table or something and you don't even know what happened because your brain trying to process that. And then we have the emotional cue reactivity, the blue one, and physiological cue reactivity. And this is also related to number 18 and 19, exaggerated startle response. This is the overgeneralization of fear. That's kind of very natural phenomena that we know for a long time, that when something painful happens, we tend to overgeneralize it. And if we avoid 6 and 7, we cannot reteach us, that some places are, and then you have to go out and work with patients to really start to exercise the prefrontal cortex area to stop and modulate this fear. So that's the other system. And then we talk about negative belief about the self, blame, all those cognition. And that's when you do psychotherapy, either psychodynamically or CBT. You talk about the patient and what the belief system and is it right or wrong. Just as a conversation between you and the patient to reshape, rethink about the maybe distortion cognition or maybe true, because we said it's not always if you did something bad. You did something bad, you just have to make sense of it. You're not, if you've done something bad at war, doesn't make you a psycho killer. Hopefully you're not coming back home and started to kill people, on the street. So most likely there is reason, and I think in a war, you have a totally different set of mindset. You're not behaving in the same way because again, you need to survive, and not just you need to survive. Sometimes you're fighting for a nation. There is a mission, and then there is the loss of interest, detachment, number 12, 13, 14, 15. All of that are like really your reward system is dead. You can't feel any pleasure anymore. You're just down. And that's something that really most cases need pharmacological intervention. So, that's what is so complex with PTSD. You're dealing with like so many different systems that working together as a therapist, whereas that's really not the case when you're dealing with phobia or OCD. You have very concrete things, or depression. Just dealing with cognition and mood. But here you're working with like 4 or 5 different biological systems that interact. Psychopharmacologically, we talk about how to deal it, and psychotherapy. And what is hard is those stories are painful. It's different to hear a story about someone depressed and talk about how they are failing and how hard it's for them, and it's hard. But when you're sitting with a woman that talk about a rape and how violent it was, and how you cried with her, I cried with a patient. Because it's hard. There's no shame in it, and that's indicating to them that you feel the pain with them. You have a soldier that his best friend, killed himself because he couldn't deal with it anymore. People that work with trauma, you need to take care of yourself too, because this is so hard. This is one of the hardest jobs that one can do, is listen every day to those horrible stories. And you took upon yourself a very hard work, and it's important because you can help those people. We know that treatment work for 50% of the patient. Hopefully with new technique we can get it better and more, and we're talking about it, but it's something that you have to remember always. Take care of yourself, make sure that you are doing something positive, exercise, go and have fun with friends, because listening over and over again to trauma is extremely hard job. So thank you. I think the translator probably lost her voice. So let's time for questions. Any questions?
Дякую за гарну презентацію. І я виписав 2 запитання. Які основні причини стійкості більшості пацієнтів з ПТСР до фармакотерапії? І як ці причини є пов'язані з дофаміновою дисфункцією? Це є перше питання. І друге питання, як дофамін впливає на стратегію подолання стресу, і які дослідження свідчать про роль дофаміну в стійкості або вразливості до ПТСР. Дякую. Як дофамін впливає на стратегію подолання стресу, і які дослідження свідчать про роль дофаміну в стійкості або вразливості до ПТСР.
Thank you. Okay, so this is area that I would not extremely expert on the dopamine system here. The only things that comes to my mind right now, and maybe Noah can talk about it. We have some research that looked at decision making and avoidance in people with PTSD. And a lot of the dopamine expression in the striatum, okay, elevated dopamine, it's interfering with making decisions about how to act in a certain situation. So I'm talking about a system that dopamine interferes. So if you give normal people dopamine, in order to make some decision about risky situation, they will overestimate the risk. Under risky, we ask them to do some risky decision making in a computer task. And we saw that they are much more likely to avoid the situation, meaning that they're not engaged. They tend to overestimate how dangerous is the situation. So it's kind of interfering in decision making about things that happening to you. So I think there is some relationship in PTSD. We show in PTSD patient that this striatum dopamine level is really interfering with ability to overcome avoidance, because they tend to over-exaggerate how the situation is dangerous for them. And then they tend to avoid more, depending on, but we looked only on striatum area of the brain. So
повторна травма, до якого кластеру вона зараз відноситься, чи є вона саме якось визначена в ДСМ, чи програмно, чи вона відноситься до ПТСР, чи іншочистої служби?
Is the curious problem in the DSM? No, I don't think it's not in the DSM. And that's something that I think us as a clinician have to be extremely aware of and make sure that we are reflecting on what's going on us and having. And I would assume that, let's think about the symptom words. It can be related to exactly whatever you're experiencing, because some people will start avoid. After listening too much to trauma, as a therapist, you might start to avoid talking about it with the patient because it's too much for you. And then you start to engage in avoiding behavior yourself, and if you're not aware of it, you are kind of not helping the patient. It's just too much for you, and then you don't do it anymore. But the patient needs you to be able to hold them when they talk about the trauma and make a story for that. And you might start to get depressed, and you start to feel other symptoms of PTSD too. So yeah, but it's not in the diagnosis. It's no. Yep.
Thank you for your time and the lecture presented. I have rather a personal question. Can you share your ideas and your experience how to overcome patients' avoidance for service?
How to help overcome patient avoidance. We're going to have a whole talk about trauma-focused psychotherapy tomorrow. So, the only advice that I have is that you're working against resistance. Again, there is only installing in the patient this belief that what you are, the journey that you are taking them into is gonna help them. It's just, it's something that you build a relationship and they can build the trust in you, that you can hold them and they're not gonna fall apart. It's different from, a soldier might not trust you that you can really deal with what they've done. And other patient will feel that they fall apart. They will become, if a woman that has so much rage and anger is afraid that she will express it all, she will become a monster. So you have to build that in a long working relationship to them to able to, and it's a lot of supervision for us too, talking to someone expert and in a group or individual and trying to make sure that you are not avoiding yourself, because it's always this dynamic. And we're talking about more psychotherapy techniques tomorrow, but it's hard. The patient, wants to avoid it, they avoid it all the time. And if you frame it in the psychodynamic, there is resistance and there is defense mechanism that people use, so you can work to unfold those defenses or depends if you are more CBT one, you need to think about ways to work with the patient to understand what does it serve this avoidance, is it, so there is different techniques to work around it, and I think supervision is so much needed with trauma-focused psychotherapy. But the patient tends to resist. They resist it all the time. But they came to you, so they need help. So they are already did half of the journey, unless they are mending the time. They're totally different. But if they're other, they already want help. And we just want to convince them that the help they're going to offer them is a path for feeling better. And I always say, your memory is going to be painful forever. It's a scar. It's as we talk about losing a limb or something, but I want you to have a control over that memory. You just give in control. Whereas the memory controlled them now, after the treatment, they will have, it's only a neural representation. You have to remember. It's not that it's happened to you, it's feel like it's happened to you again. But this time it's, when you are in the field and bombs falling, you have no control of it. But over the memory, you do have some level of control. So you need to differentiate that in some way. For the patient, you want to give them power in this process. You make them more powerful. They're not helpless people, And sometimes it's helped them to understand that they need to go, and it's not happening to you. It's just a memory. And two different things. So you're being right, or a memory. It's two different things. Okay. One.
Доброго дня. Таке запитання хочу запитати на рахунок, чи вивчали ви якісь особливості трансграфічних ритмів під час протікання ПТСР і під час терапевтичного процесу. Тобто, наприклад, альфа, бета, активність в лобній ділянці, префронтальній чи потиличній. І наступне питання, чи використовували ви нейрофідбек в терапевтичному процесі до ПТСР? Дякую.
Okay. So, do you have some data on EEG?
Sure. We can. So, this gets back to the question earlier, which is we use all the tools that we can, and we can see changes in our EEGs as people go primarily in power domains, primarily in alpha and theta, as people get better over time. In my work, we've not seen it, it's not quite so tightly linked with their symptoms. They're sort of happening at a different speed. Usually the EEG changes are happening before people start talking about their symptoms getting better. So there's a different process that's going on in the brain first. And you can speak. Do you want to speak to neurofeedback?
I can talk to our study in neurofeedback.
That's yours.
That's okay. So we use a different method of neurofeedback. Because I'm very interested in trauma memory, what we have done is recorded again the trauma memory for the patient, several versions of it, and we did a real-time fMRI because we're using fMRI. So when they're listening to the trauma, they saw a line that showed the amygdala activation to the trauma. And they had to look at the line, and then when they finished listening to the trauma, they had to down-regulate it, to push the line down of the amygdala activation to develop their own methods of inhibiting, pushing down the amygdala activation. And we did 3 sessions in the MRI, and we showed that really people that really were able to develop technique, and we gave them we didn't say whatever works for you. We didn't tell it any technique. The people that gave us the money asked us to give them, teach them about reframing, other technique or mindfulness, just that they have some tools, but we tell them use whatever you want to use. And we showed that 30 days after the treatment, it really was the ability to down-regulate those neurofeedback really were associated with reductions PTSD symptoms in 30 days after finishing the treatment. So people that really learn how to down-regulate well were really experiencing better symptoms. And again, it just was a technique to show that you have control over the memory, and that we use those trauma memory. I know that here you're using, in the hospital they have a neurofeedback module. We want to learn what you're doing here. fMRI is very expensive, and it was just to see another way of how we can control our memories. But this is very expensive and hard to implement widely. I think those systems that you just have physiological reactivity are very good systems that you can work with these patients.
А скажіть, будь ласка, чи досліджували ви зв'язок безпосередньо між травмою, запахом і звуками? От, власне, не візуалізація, а чисто запахи, і звуки і травма, глибина травмування. Як воно пов'язано наскільки глибоко з пам'яттю? Наприклад, як військові, я як військовий, наприклад, у мене асоціація, наприклад, страх, смерть, має певні запахи, певні звуки. Чи ви якось це досліджували в процесі для того, щоб пізніше на основі того розробити нові методики лікування, власне, стресових розвитків?
Thank you so much. It's very important. I talked about the olfactory phenomena, that everything, when you're encoding the memory, so the smell, the sounds, and not just the vision, are linked together to create this memory of the events. So, smell goes directly to your brain. This is a very strong memory activating system, and then when it's hit the memory trigger, it's trigger the entire visual and everything that was encoded with that specific event. For me, smell of burning flesh is very strong because we have an event that a vehicle with people was hit, and we had to connect they remain, and I remember always the strong smell, and that's the treatment that what we are working on in the reconsolidation is just that, is just making sense of that story. So when you're gonna have a smell, you're gonna have a memory, and this memory is gonna activate, and then how you're gonna deal with this memory. But we not working directly on techniques of remodifying different sensory. I don't know if your group working on something.
We're not gonna. Yeah.
And here's another expert.
Sure. So one of the things, and maybe we'll have some time to add it into the schedule. One of the things that we do with our service members and veterans is put them through a very immersive virtual reality experience that includes olfaction and haptic and visual, and then we combine that with other techniques and technologies to enhance the learning process, but putting them all together. Because just as you said, those memories, particularly olfaction, are just very, very, right? It's cranial nerve 1. It's a really, really important connection in the brain. It goes straight in. And maybe if we have some time, I'll add that into some of the other talks. And we can use, and let me give you sort of a more positive and important spin on it, is that because these memories are so strong, right? We can use them and access them a little bit more quickly, and work to help people regulate what the experience is when they have those memories, if we do it gently and carefully over time. Sounds like I have another lecture.
Yeah,
That's fine. We can.
Yeah, because again, in the virtual reality, we have like different smells that it's activating, like depends on the scenario, it's releasing those smells to the environment, and that helps to activate all the mechanism and try to create a better treatment that deal with all the sensories that were activated. So yeah, the virtual reality that Noah is going to talk about his research on that with combination with other modalities together. Also a way to help people that really a lot of smell, a lot of noise, a lot of noise. Sounds that really like resonate and reminds people a lot of things that happen. There was one more question.
Ви казали про функціональне МРТ і нейровізуалізацію в цей момент, і нейрофідбек. Яким чином пацієнт може бачити цю лінію активності металика і на неї впливати в апараті? Як він в апараті це може бачити?
So it's on the screen. Yeah, we have a screen inside the MRI, but it's a program. It's a computer program that we developed that immediately reads. And it immediately reads the data, analyze it, project it to the screen. So we can install, let's say, in an MRI, if you have functional MRI here, we can install this program and use it.